very quickly go through a few things here. Just my disclosure, and in this presentation, there's going to be some patient information. So I just want to point out to you that I want to acknowledge my patients for letting me use their videos. I also frequently use pro sections, but in this presentation there are no pro sections. So if any one of you are taking any pictures, feel free to take any number of pictures, but just I would kindly request that the patient information not be a picture taken of. Now, I work at the Glenrose Rehabilitation Hospital, which is one of the largest freestanding rehab hospitals in Canada. And in the hospital, we have 244 beds. 100 of them are dedicated to adult patients. And I just want to point out a few things here is that we see about 1,700 inpatients per year and about 80,000 outpatient visits a year. This is for all of neuro rehab and musculoskeletal rehab. Now, when I went to the Glenrose many years ago, I went out with a mission to start up a spasticity interdisciplinary program, and this is almost 12 years ago. So we called it the spasticity program for adults, and as you can see, the mnemonic is Glenrose Spa, and we built it on three important clinical pillars, and I'll let you figure out which pillar is really holding up the spa. But importantly, we had a chemo denervation program in there. We had an intrathecal baclofen program, complex medical dealing with the whole patient as a whole, and pediatric transition. And more importantly, right from the get-go, we had neurosurgery working with us. We had orthopedic surgery working with us. And more recently, we have brought in plastic surgery as well. And I've been very fortunate here to have a dedicated team for spasticity. So I have all these professionals. I have 2 nurses, 2 physios, 2 OTs, and 8 physiatrists and 2 clerical staff, all dedicated to the spasticity program. We have very close ties with orthotists and the gait lab, most importantly, and pharmacy and seating. Having said that, very quickly, just to give you a sense of the growth in that clinic over the years, we currently see about 300 new patients a year and about 2,000 patient visits a year. I know for Europe this might sound a little bit lower, but for a Canadian center these numbers are very high, the numbers that we see. And more importantly, I just want to touch base on the interdisciplinary orthospasticity clinic that we have going. We see patients in an interdisciplinary manner, and I think very nicely Rajiv earlier talked about the multidisciplinary, interdisciplinary, and transdisciplinary. When I first started in 2006 and sent the first patient through the gait lab and sent for surgery, we were very multidisciplinary at that time. And since that time, and interestingly at that time, it would take 2 to 4 years to see a surgeon. Orthopedic surgeon, and that's how long it would take for us to get somebody seen for any type of intervention. So that's when I started talking to orthopedics and brought them on board. And now we have the orthopedic surgeon coming to us in the gait lab, and we see patients together. We've seen about 44 patients for foot and ankle surgery through the gait lab, and we actually started the interdisciplinary clinic about 3 years ago, and we have about 3 or 4 clinics a year. And we've been quite successful with these clinics, and I must say the outcomes are also very rewarding. And on the team, we have myself, physiatrist, we have 2 orthopedic surgeons, physical therapists, kinesiologists, and a nurse who help us. By the way, I hope I'm not speaking too fast for any one of you. I'm a bit slow, okay, I will do that. And everybody can understand me, correct? The audience, okay. As I said, we see people in an interdisciplinary fashion, and what happens in our clinic is every patient that has to have surgery has to be referred to the spasticity interdisciplinary clinic. From there, every one of them have gait analysis. Even if we are dealing with toes, what we do is we don't get a full instrumented gait analysis, but we'll get the pedobarograph done and high-speed video, so we have things to document. And then we have a team meeting of pediatric orthopedic surgery, myself and the kinesiologist, to talk about the outcome from the gait lab, and then from there onwards we will bring the patient to this interdisciplinary clinic where this is our orthopedic surgeon. We see the patient in the gait lab collectively and collectively decide on what needs to be done for this patient. So, it is, I have learned a lot from my surgeon, and she says the same thing about me, because I think we heard this quite a bit in the last few days, where the surgical disciplines and the MPR, correct? MPR are coming together for the betterment of the patient. Then they go for surgery, and after surgery, they are transferred to our rehab hospital for rehab, and then we continue following them indefinitely in our clinics, in the spasticity clinic. As I said, we've seen about 44 patients. We've already had 35 have gone through surgery, 4 have declined, 5 are waiting surgery. And interestingly, we have currently data on 26 patients that have 1 year post-surgery. Age range of patients going for surgery, 29 to 64, about 48 years. Male, 12, and female, we see more female patients. Right and left, you can see almost equal. One bilateral, which is a CP, and just show you some diagnostic things that we see in the clinic. As for surgical procedures, I know we've talked a lot about this in the last few days. It's a lot of what you see here. I'm going to address this EHL tendon lengthening shortly. And by the way, we don't do any arthrodesis. This was a patient that had arthrodesis done before they came into our clinic, but not anymore. And as for outcomes, I must say the pain is a big thing. Patients really find a big improvement. Time up and go walking is also decreased. I unfortunately don't have the data. My research nurse sent me the data yesterday, but I realized there were a lot of patients who had been walking without an AFO after surgery, and their gait speeds were not. So I have to look at the data more carefully. So I'm not giving any numbers for this. But overall, I can tell you clearly, patients are extremely pleased with the outcome. The 35 patients we have, I can't recall anyone that is unsatisfied with the outcome following surgery. Now, a little bit about the Glenrose. We work very closely with the Sensory Motor Research Laboratory at the U of A. And Vivian Mushaba, who is a neuroscientist, works in our department, and she has been doing a lot of intraspinal, setting up we talked yesterday about using intraspinal stimulation for human ambulation in spinal cord injury. And she's been doing a lot of work in this area, and I think some of you who were there visiting our center last year, Terry and Franco, you all did get to see the stimulator, the electrodes that she had made, and they are just about ready to now implant these electrodes in a human spinal cord injury patient. And another person that I collaborate very closely is Monica Gorasini, and right now we are looking at some animal studies and human studies, primarily trying to look at the central botulinum toxin effect. And this is expanding from the work that Matteo Callio has done in Italy. And another area that I also collaborate is with clinical engineering. And just to very briefly tell you about a project that we're working with robotics is we have these patients on whom we have, I'll just get the volume up here. A patient on whom we put a bunch of electrodes, and we're trying to pick up any electrical signal that comes. Using artificial intelligence, we're trying to send the signal into a computer and use that to operate a robot and get the patient to use it. We're in early stages at this stage, because you will notice it's not the regular function, but it's just picking up electrical signal and seeing what we can do with this signal down the road as we move into the area of artificial intelligence. So it's a very early stage, but this is another project that's going on at our center. So that's a very brief description and a rushed description about my clinical center. I'm now going to talk about toe clawing. So I know we had a very interesting discussion a little while ago about toes. I want to try to focus a little bit on the big toe as opposed to the small toe. I know there's a lot, if you look at the literature, there's a lot of stuff, even from an anatomy point of view, that has been described with the lesser toes, but the big toe is a bigger challenge. And the objective that I want to share with you is, what is clawing, what is flexion, what are the muscles involved, FHL, EHL, or both, FHB, EHB. And as a group, I don't know the answers for this, but I'm going to try to propose some ideas to the audience today, and we can open it up for discussion. but this is probably what I want to talk to you about today. So anybody know what is toe clawing? Anybody know where the name came from in the audience? Anyone? Any of the surgeons? Toe clawing. Interestingly, it came from an eagle's claw. Really look at an eagle's claw very carefully. You will notice there's an element of hyperextension and there's an element of flexion. So this is how the term toe clawing came. Okay, clawing. Sorry, the term clawing. Forget toe clawing. So you all know ulnar neuropathy. You don't call an ulnar neuropathy unless otherwise you see hyperextension at the MCP joint. Then it's only then that we can really confidently call it an ulnar neuropathy. So if you know, look at this picture here. Here is somebody, a patient of mine who has spasticity. This is not clawing. You don't see any hyperextension of these digits here. So I just want to make that distinction for us that whenever we use the term clawing, we need to see hyperextension at the MCP or MTP joints to really describe this. So what is big toe clawing? I'm sure this picture is very familiar to you. You know, we have a number of patients who come with hyperextension and flexion of the toe, and when people ask me how do you manage this, over the years I honestly have struggled to determine what I should do. When there is no hyperextension of the toe, you see this toe now, right? This is quite flexed. This is not hyperextended. So this is not, in my mind, a clawed toe. So make that distinction between toe clawing and toe flexion. For the surgeons in the room, foot and ankle surgeons, this is a very common thing that they talk about: claw toe, hyperextension and flexion of everything else, hammer toe, everything is straight up to the proximal interphalangeal joint and flexed, mallet toe, straight out, and just the terminal phalanx is flexed. This applies to our lesser toes. A big toe is different. Why? We only have 2 bones in our big toe. We don't have 3 bones. So we cannot end up with a hammer. Typically, we cannot end up with a mallet. And correct me if I'm wrong, from the surgical world, I have not heard these terms being used as hammer and toes for the big toe. So therefore, there is a difference between the big toe and the other toes. So having said that, I'm going to present this case to you. 42-year-old lady with MS, started in 1998, primarily a left spastic hemiplegic. And I just want you to look at her video here. I'm going to slow this down a little bit for you so you can have a look at it even better. So let's pay attention to her first rocker. First rocker meaning where the ankle is rolling over. It's barely rolling over. You can see that, right? She just comes and lands, and ankle barely rolls. Then let's look at the second rocker where the tibia is rolling over the ankle. You can see we have only just a little bit of range from there to there with tibial rocker. Then she has a third rocker and doesn't have a fourth rocker. So can I just get some ideas from you as to how you think you're going to manage this, whether it be injection or surgically, doesn't matter. What tendons are, what muscles are you going to focus on? Can I get some ideas from the audience? Anybody? This is a patient walking into your clinic. How are you going to deal with this? So the patient is going to complain of a lot of pain. This patient has a lot of pain in the foot. We examine the foot. There is difficult to localize, but there is pain there. There's a lot of pain there. Okay, so varus of the foot, you have supination of the foot you're concerned about. Okay, so can we just put our focus onto the long toe flexors and the short toe flexors? Anybody want to do anything about that? This woman, no, she's complaining of a lot of pain. So what would you want to do? So you're going to work on the ankle. Very good point. Okay, so we've already said we're going to work on the ankle here. Right, we correct the ankle. Sorry? Hyperextension of the knee, sure, there's a problem there. So we're going to work on these things. What's going to happen to our toes is a big question, okay? So let's go to this. And I'm going to walk you through this. So here's another patient, not the same patient, but I just want to highlight a few things here. What bothers me sometimes is look at the EHL, right? Yes? Sorry. You look at the EHL here, you see how prominent it is, and I just showed you in the other video as well. EHL tendon is very prominent. And is the EHL tendon very spastic and causing this problem is my question to you. Trying to help the dorsiflexion, okay? So I'm going to show you, well, we'll hold that thought and come back to it in a minute. I'm just going to very quickly talk to you a little bit about the EHL tendon, and then maybe I'll do that right now. Sorry, I just have to step out a little bit here. Just going to show you a model. Let me just skip a few slides here. No, I'll come back to that, sorry. So here's your EHL tendon, okay? You see your EHL tendon here, and I'm just going to show you the extensor expansion and just talk a little bit about this. Here are the bones, and here you find, the EHL tendon going all the way out there. More importantly, sorry, time. Okay. I understand there is extrinsic contribution, all of these contributions. I'm going to skip through some of this because I want to talk to you a little bit. Can I have 5 more minutes? No? No? Wow. Okay. Okay. So, I just wanted to talk to you about a very important concept about the foot. I'll just very quickly talk about it. If you all look at the foot here, right, we go into plantar flexion. What happens to our big toe? You see, right? It is not the toe, right? So I'm going to show you one more video and then I'll stop, Tony. This is just all anatomy. I want you folks, when you go home tonight, if you can close your eyes and focus on plantar flexing, your toes are going to end up pointing upwards, right? Don't point your toes down, but point them up. I want to point out another thing to you. Look at this here, right? All of you can cause this toe clawing by contracting your FHL, right? Now, I'm going to show you my other leg. I did a needle tenotomy on this, and I can't do that. Interestingly, I have a spontaneous FHL rupture on my other side. So I'm a perfect example to show you what happens to this muscle. You see, this is all the extent flexion I can get. And this is FHB flexion. There is no FHL, right? I can't do anything beyond that. So when you have plantar flexion, we see the big toe go up like that. You add now FHL tightness, it bends here, and now you get a clawed toe. So whenever you correct your plantar flexion, you need to deal with your toe long flexors. If not, you're going to end up with a flexed toe becoming a clawed toe becoming a flexed toe. And this last one I'll show you. This is a patient that pre-surgery. This is after TAL lengthening. After TAL lengthening, you can see what happened to the big toe. It became a flexed toe. So then we went on, this is in 3 stages, we did this surgery. Then we went on and did TAL and FHL lengthening, and then things corrected, right? So you can see what a big difference it makes to actually address that big toe when you're doing all of this. And you can also see the difference in her gait here. In the interest of time, I'm going to stop here, but I'll be happy to answer questions further, right, later on, and we'll go from there. Sorry
Thank you very much. Thank you.